including both inpatient and outpatient psychiatry, providing care for children and adults with all types and severities of psychiatric illnesses. Her area of true passion and expertise is reproductive psychiatry. She has spent the majority of her career dedicated to to that specialty and currently maintains an active clinical practice exclusively focused on reproductive psychiatry, where she primarily cares for perinatal patients. Beyond her clinical work, Dr. Reichenbacker has made significant contributions to academia, where she served as an assistant professor and the PMHNP program coordinator at the University of Virginia School of Nursing. She is also actively committed to improving access to high quality mental health care for patients in the perinatal period. In pursuit of that mission, she regularly presents at regional, state, national, and international conferences on the topic of reproductive mental health, works with local and regional stakeholders and advocacy groups to improve awareness and access to mental health care, and volunteers her time providing clinical instruction to PMHNP students. So I will turn it over to you, Dr. Reichenbacker.
Thanks so much, Tiffany. Okay, so I'm really excited to be here for the last webinar in the series. This is, I think, probably of all the topics that we've discussed, the most practically oriented. We're going to talk a lot about some really specific steps, procedures, processes to complete an appropriate safety risk assessment. And those types of things are generalized to any psychiatric safety concern. But we're going to narrow it down to some of the specific things that we need to think about in the perinatal period when that comes up. So actually, Tiffany, before we get started, is there any way we could ask the audience to see if they can just briefly like shout out in the chat? Maybe you could read that off since I can't actually see the chat in my screen right now, but like where they're like what kinds of settings they're working in, because that does kind of play a role sometimes in like how some of these safety risk assessments can happen. Or their roles in those settings, those kinds of things. Just like a few briefly, just to kind of get an idea would be helpful.
Absolutely. Everyone, feel free to drop that in the chat and I'll read them off as I see them.
Okay, great. Thanks.
Women's SUD recovery therapist with perinatal clients at a CSB.
Okay.
RN/NICU family support coordinator in NICU.
Mhm.
Allegheny Highlands Community Services, Project Link Case Management, birth doula, hospital birthing centers and homes, maternal child health coordinator, Blue Ridge Health District,
Nice. These are awesome. So such like variety here. This is great.
MCH home visiting nurse.
Cool. Okay. So I think a lot of you all will be familiar with a lot of what we're going to talk about today, which will be good because we're going to talk pretty in depth. And what I would just say ahead of this is a lot of this will build on some of the other things that we've talked about throughout the series. So if you haven't, like, for example, seen the webinar from the last time or some of the earlier webinars, you might want to go back and look at those. There's going to be some things that, have been built on. We're not going to go in depth about today. And then the other thing is like some of these steps and some of these things are going to be more um, pertinent to some of you and less pertinent to others. But everything you're going to learn here is going to hopefully increase your comfort level with dealing with these psychiatric safety concerns. And at the very minimum, give you the picture of like what best practice should be. And if it's not happening in the settings that you're in, having, the ability and confidence to be able to, update your own practice or try to update the systems that you're working in. Anything else that any felt sense before we move on, Tiffany?
Yes, I saw that there is a postpartum doula, a clinician in the Project Link program and a program manager working with pregnant parenting moms with SUD and co-occurring disorders, and then a women's service educator for a new L&D and postpartum nurses.
Oh, I love all this. This is great. Okay, I'm excited to have all you guys here. Great. Okay, so this is going to be a good fit for I think everybody. Okay, so what I want you all to be able to do today is recognize safety concerns in perinatal patients, be able to identify the specific steps to help prevent crisis in high-risk patients or help prevent the safety concerns for evolving into like attempts or actions, and understand the process to intervene effectively when crisis is already occurring. And then finally, be able to differentiate between true perinatal mental health crises and non-emergent psychological distress that can sometimes look like those things. It's a big problem. Psychiatric crises are one of the leading causes of maternal deaths. 1 in 4 are attributable to these psychiatric issues, which would be suicide and overdose. And I think the most concerning thing that I've seen as I've been looking through the literature for this information is like this problem is getting worse. So over the last decade, and more so even probably since COVID, there's some variation in how clear that is. We've actually seen a rise in maternal mortality. And some of this increase is definitely because we're better at capturing these people. There's been better reporting, especially for maternal mental health related deaths. But it's pretty clear that even with that improved reporting, there is an actual rise that reflects some kind of systemic issues. So obviously there's some big problems that we have, but at the face-to-face patient level, there are definitely things that we can be doing better that we will talk about today. Again, a huge portion of this maternal mortality is because of these mental health causes. In OB settings, about 2 to 5% of pregnant patients experience suicidal ideation. And remember that this is like the general population setting, right? So when we think about an OB setting, this is basically general population in the research that that was looked at here. And that's the lowest risk group, right? There are a lot of higher risk groups that you all are working with. People with very low income, limited access to services, people with chronic illnesses, or pre-existing mental health concerns, right? All of those groups would be expected to experience, in some cases, much higher rates of suicidal ideation. The baseline estimate for veterans is 10%. That's already quite a bit higher than that general population rate. And while there's been this sort of long-standing belief that pregnancy is protective against suicidal ideation or attempts, and we'll talk a little bit about homicidal ideation as well. Basically, the evidence suggests that that protective effect, if it exists, is minimal at best, okay? Yes, absolutely. Most of the suicidal behavior and completed suicides will occur in the postpartum period. So 3/4 of all suicide deaths occur between 6 weeks and 1 year postpartum. But the ideations very often begin much earlier. And of course, there's still 1/4 of people who will attempt or complete suicide earlier on in pregnancy. Um, Part of the reason why, even if there's a protective effect, like perhaps people attempt suicide less often in the perinatal period, but that protective effect theoretically is minimized, is because when attempts happen, much more lethal means are used. So people will use methods like firearms, for example, at much higher rates during this window than they would generally. Um, and then finally, just a little note on infanticide and filicide. It's extremely limited in the research as far as like being able to understand what those numbers actually are. It is rare, for sure. It's a rare occurrence. But it's something that because obviously the nature of that is so extreme, accurate reporting is really, really difficult. So the takeaway, rare, but it does happen, and it is something that we're concerned about. There's just not great stats on it. You'll see, I think last session we talked about how in very high risk groups, like people with postpartum psychosis, for example, maybe 5% of those people will complete infanticide or filicide. So extrapolate that, that's only maybe 1 to 2 per 1,000 people will experience postpartum psychosis, and then 5% of those may complete infanticide or filicide. Okay. So this is the asterisk on this. And while this is obviously a devastating topic, the risk in perinatal patients is almost exclusively associated with perinatal psychosis. So for that reason, we're going to focus today, when we talk about this risk assessment, we're going to focus specifically on suicide risk assessment. We'll talk again in just a moment here. I'll say this probably 4 or 5 times today, but The same processes and procedures that you use for suicide risk assessment, for the most part, can be extrapolated to general safety risk assessment and risk assessment for homicidal ideation. But in the perinatal period, because infanticide and filicide and these types of homicidal ideations occur almost exclusively in psychosis, the focus is on assessing and preventing um, the psychotic episode and being able to identify the psychosis specifically, rather than any specific homicidal ideations, if that makes sense. Okay. When it occurs, when infanticide or filicide occurs, it's almost always linked to altruistic delusions. So this means that the individual believes that they're acting in the child's best interest, protecting them from harm, or ensuring some kind of better existence. Okay. In perinatal psychiatry, psychotic symptoms alone constitute a psychiatric emergency, even if there are no explicit homicidal or suicidal ideations, because psychosis can cloud the patient's judgment and perception of reality, and also can cloud like their ability to report these symptoms. Delusions in general, people often will not freely offer those thought processes up. So it can make it really difficult to accurately assess for not only even just the presence of these types of thoughts, but also accurately assess other types of things to make a solid risk assessment, like assess intent and things like that. And in the nature of psychosis, judgment and insight is very limited. We'll talk about, why that's important a little bit later. So again, just the act of experiencing a psychotic episode alone is a psychiatric emergency. It's a psychiatric crisis, and we intervene even when there are not explicit homicidal ideations stated. Recognizing and addressing the psychotic symptoms is the key, and that's what we look for here. So if you haven't seen the last lecture, please go back and feel free to watch that. We'll talk very briefly about some of the key hallmark symptoms to look for, but it will go into more in-depth last session. Okay, let's see. Okay, so today we're going to spend, again, the majority of our time focusing on suicide risk assessment and prevention, again, because of the considerations we have for addressing homicidal risk. When we think about suicide risk assessment and prevention, the two key components of risk management are assessment and prevention, okay? In the assessment process, our goals are to identify accurately people who are experiencing suicidal ideation or homicidal ideation, if you're broadening to safety risk assessment, and evaluate the severity of that risk by exploring items like plan, intent, and means to determine basically how imminent the risk is. Prevention involves implementing safety-oriented actions tailored to the patient's level of risk. So those can include things like creating safety plans, engaging support systems, connecting patients to appropriate resources, or in some cases, escalating patients and referring them to higher levels of care. A key part in both assessment and prevention is recognizing population-specific risk factors like those for our perinatal population, and also protective factors, which can mitigate the risk and also help guide interventions. Give me 1 second. Apologies, everyone. Okay, so risk factors. We mostly think about risk factors in the context of someone who has already been identified to have suicidal ideation. Okay, so these are factors that may increase the risk of somebody actually engaging in suicidal behavior. So they actually attempt suicide rather than somebody who may persist with ideation but not actually go on to attempt. However, you can also think about some of these as risk factors for people who would just be at higher risk of developing a psychiatric crisis in general. So keep that in mind as well. You can certainly potentially intervene even earlier for people that you can identify as high risk for psychiatric crisis. And some of these risk factors are just more general to suicide risk in the general population, and the others, like the first few, are more specific to the perinatal period. So prior suicidal ideation or behavior, while that is absolutely a risk for anybody in the general population for suicide behavior, for perinatal patients, it seems to be one of the most important risks. And it's something that we should be ideally assessing for, if at all humanly possible, when we're interacting with these clients. A personal or family history of bipolar illness, perinatal psychosis, or other severe psychiatric illness are also significant risk factors. And as is any active psychosis. Active psychosis is one of the most major risk factors that we see for perinatal patients because most of the suicidal or homicidal behavior that occurs in the course of a psychotic episode. Just certainly not all, but a good chunk of it for these patients. Alcohol or substance use. So this increases impulsivity, which is a huge factor in suicide attempts. An important reminder is that although people can experience suicidal ideation sometimes for like weeks, months, or I mean, even years, the actual attempt is almost always impulsive. And that can be unusual for people to hear because we think about people having like a plan for suicide as being a really important component of like assessing risk. But usually when somebody actually does end up acting on suicidal behavior in that moment, like that decision to do so, even if they've had a plan prior, is usually a very impulsive one. So anything that increases impulsivity is going to increase the risk of suicidal behavior. Recent losses. So this comes up for the general population, absolutely. But a really critical type of loss that we see in the perinatal population is obviously pregnancy loss and child loss. And so this is something that I think at times can be swept under the rug, especially depending on if pregnancy loss happens at an earlier stage when somebody else might perceive it as not as impactful. But losses are an important risk factor for suicidal behavior. Cultural or religious beliefs that suicide might be an acceptable resolution to a personal dilemma can elevate risk, and especially social isolation. Social isolation is a huge risk factor. Anytime people lack a supportive network, feel disconnected from family, they're definitely at a higher risk of suicide completion. Um, Protective factors. So protective factors are the elements that reduce the likelihood of a patient acting on their suicidal ideation. And ideally, we can recognize and leverage these factors when we're doing safety planning with patients. A sense of responsibility to family, like a spouse, children, or parents, is one that is uh, true for the general population. But in perinatal psychiatry, this is something that we very often see as like a strong motivator. These are typically, parents with young children. They feel a huge sense of responsibility to them. And we can help them elicit this and leverage this as part of the safety planning, as part of their motivation to seek help and stay safe. Religious or cultural beliefs that on the opposite end, suicide is not acceptable can be a barrier against suicidal action. A general satisfaction with life, so people who overall feel a sense of well-being and fulfillment, that's a positive protective factor. Having good, strong social support is a huge positive protective factor. And we know from the perinatal population that building social support and building support networks is also a huge protective factor against psychiatric illness in the perinatal timeframe in general. Access to healthcare and resources. Obviously, if people have better and easier access to the resources that they need, they are less likely to act on suicidal thoughts. And also, very importantly, coping and problem solving skills. And we can help patients to identify their own skills that they already know that can help them deal with stressful situations, challenges, and worsening emotional states that can help to reduce the risk that they will resort to self-harm. Essentially, we want to basically, when we're assessing for patients with suicidal ideation, we want to assess both of these factors so that we have a much better overall understanding of their risk. One of the most critical aspects of a safety risk assessment is identifying the people who are actually experiencing suicidal ideation. Okay. Primarily, this is going to happen through the specific statements or interactions that you have with the patient. Okay. These can be overt statements or covert statements or nonverbal clues. But that is going to be where your data comes from, right? So you have to spend time sometimes with the patient, talk to them, ask them questions, etc. This information is not necessarily readily available to anybody else besides the patient themselves and only available to you if they share it. Overt statements are clear, direct, and obvious statements that a person is contemplating suicide. So some examples would be, I'm thinking about ending my life and I don't want to live anymore. So this is obviously very clear. The patient has made a statement that death is on their mind. Covert statements, on the other hand, are typically vague or indirect expressions that can indicate suicidal thoughts. So some examples would include things like, this will all be over soon, or I won't have to deal with this much longer. Definitely concerning when somebody says that, but it's obviously not clearly a statement of, I plan to die, for example. Nonverbal behaviors can also signify suicidal ideation. Some of those can include, but please remember that there's, these are more difficult to pick up on. Giving away personal belongings, getting affairs in order, like writing a will or saying goodbyes, or attempting to access means, like things like stockpiling medications, acquiring weapons. I find that a lot of times the nonverbal clues come from other people, like other people report those compared to the patient specifically. Whenever possible, gathering collateral information from family or friends or any caregivers is wonderful. It can provide some great additional insights into the patient's risk. But in most healthcare settings, and I mean, from what you all shared about where you're practicing, I would bet that the primary source of information is going to be the patient. So that's why we talk to them, we listen, and we assess heavily so that we can get the information directly from them. Basically, it's going to just require pretty careful attention to what the patient is saying. Okay, so after we identify either an overt or a covert statement of suicidal ideation, the next step we have to do is to evaluate further. And really the summary of this is like, you want to clarify, clarify, clarify. So you want to ensure that you have a very, very clear understanding of what the patient's thoughts and intentions are. If the patient makes a covert statement, ask for clarification. You do not have to hesitate. You can ask direct questions like, are you having thoughts of suicide? Some people feel really uncomfortable asking those thoughts. You may have had bad experiences asking a patient, at a time in your career, questions like that, but the research consistently shows that patients, by and large, are not upset by those direct questions, okay? Even people who are not experiencing suicidal ideation typically view those types of questions as necessary and part of good care. Like they're not bothered by being asked that if they're not experiencing suicidal thoughts. There's a lot of qualitative research on this, and it's pretty consistent. People who are experiencing suicidal ideation often want help, and they are willing to share when they're asked directly. And in fact, asking directly can sort of set the tone that this is like a topic on the table, right? Like this is not something that you're scared of, so it's not something that the patient has to be scared to share. I think it's also, again, important to like understand the suicidal mindset, like remembering again, it's an impulsive act. So, um, even if planning has occurred, like this is not something that the patient is often like um, thinking in the moment, every moment about. It typically conflicts with the person's natural sort of self-preservation instincts. So even in the most severe cases, there's usually at least some internal conflict that can motivate the patient to seek help when prompted. So just asking them is a huge part of that. Okay, so the levels of suicidal ideation are passive suicidal ideation and active suicidal ideation. And passive suicidal ideation is thoughts of death or a desire to die without a plan to act. So an example would be, sometimes I think it would just be best if I fell asleep forever. And active suicidal ideation is thoughts of death or desire to die with a specific plan to act. So an example would be something like, I sometimes think about jumping off a bridge. So the key distinction is that passive suicidal ideation indicates a desire for death. Remember, ideation is in the name, right? This is something that is a wishful thought of death, but no active steps towards it. while active suicidal ideation involves some kind of specific act that would carry out death. And I think that's really essential for being able to, at the very basic level, clarify, stratify the risk. Um, Now, in order to determine whether there's passive or active suicidal ideation and even more so stratify the level of risk, we really want to assess these three critical components. This would be plan, intent, and means. So a plan is the specific course of action that the person envisions to carry out their suicide. Okay. So examples would be there can be like a general plan, like an example would be like that first statement, like I sometimes think about jumping off a bridge. There's something specific in there about like they will act to do it. But it's not like as specific as, for example, I plan to jump off a bridge at 10 a.m. on Thursday. So the more detailed the plan, the higher level of the concern for sure. Intent refers to the person's desire or commitment to act on their thoughts of suicide. Somebody who does not have intent may say something like, I think about jumping off of a bridge, but I really like would not do it. I don't have actually any desire to do it. It just seems like if I was gonna do it, that's how I would do it. Um, where somebody has intent, they might say something like, I think about it often and I kind of want to go through with it. Obviously, when intent is involved, the level of risk is higher as well. I think differentiating from ideation and intent is pretty crucial for stratifying risk. People can have lots and lots of wishful thoughts of death without having any intent to act on that. Means is basically access to the tools or methods needed to carry out the plan. So if the plan involves jumping off a bridge, does the person have access to such a location? I'm in Hampton Roads, there's bridges everywhere, right? But that might not be true in some localities. If the plan involves a firearm, does the person have access to a firearm? In general, we also want to be evaluating for the presence of high risk means. Most typically that just involves, even if the person doesn't have a plan involving a firearm, still evaluating for the presence of access to a firearm. The presence of means elevates risk substantially, especially when we combine that with any plan and intent. So some examples of like stratifying the risk when you've assessed a patient would be like a high risk patient would be positive for all three. They'd be positive for plan, intent, and means. This is a person with a specific plan, they have an intent to act, and they have the access to the means that require, or they have access to the means and would require like specific immediate intervention. Like we would be transferring this person ideally to inpatient care. Lower risk might be negative for all three, right? They might just have those passive suicidal thoughts without any specific plan, intent, or means, or they may have a more general plan without any intent or means. And oftentimes those patients can be managed safely in an outpatient setting. Um, Basically, when we stratify risk using assessment of these three areas, we can really identify the level of danger and the imminency of the risk to be able to figure out what the appropriate intervention is. Sometimes it's going to require immediate action. Other times, like lower risk, can be supported with, outpatient services. Okay, the most important component of any of this risk assessment is simply to open the dialogue, ask directly about suicidal ideation. If you take nothing else from this lecture, just remember that you cannot go wrong by asking. Like if there's um, anything that's holding you back, like this feels like an uncomfortable conversation, practice it. Practice it with colleagues, practice some of these sample questions. This is an example dialogue that you can kind of look over and review that gives you an idea of like how somebody might express some covert statements of suicidal thought and how you as a clinician would be able to get to more detail and more information that would help you better support that patient. You can ask any question that feels right to you, but some examples would be very directly, have you ever felt that life was not worth living? Have you been thinking about death recently? Do you ever think about suicide? Have you ever attempted suicide? Do you have a plan for completing suicide? If so, what is your plan? You can be as specific as you need to be, People who are not experiencing suicidal thoughts will not be upset by this in 99% of cases. People who are experiencing suicidal thoughts typically want somebody to open the door for them to get help, at least deep down. Okay. So after we do our suicide risk assessment, the next step is determining which interventions are appropriate. Okay. So if you're in an inpatient setting, there is almost zero chance that you do not have a very, very specific organizational procedure for what to do in the case of somebody expressing suicidal ideations. So follow those procedures. If you're in an outpatient or community setting, especially if you're in a larger facility, you probably do have some kind of policy or procedure. So if you have one, follow it. If you don't, or if your policies or procedures aren't super detailed, like they don't go much beyond like the actual initial assessment part, you can use other resources. The safety card is one of my favorites. The snippet of it is down here in this chart that I've included, and I've got a link to it later in this lecture that you can access. And I think it's a really good option because it helps with both risk stratification, but also with possible interventions. So, some intervention options just briefly for basically you would consider inpatient psychiatric hospitalization for patients who have active suicidal ideation who are positive for plan, intent, and means. In those cases, it would be very difficult to think about a way to manage that patient safely in any other setting. Outpatient psychiatric care can be appropriate for patients who have passive suicidal ideation or even a moderate risk level that have also modifiable risk factors, a lot of protective factors, and for whom you can create a mutually agreeable safety plan. Anytime you're in doubt, refer to your nearest emergency department or the behavioral health crisis unit. Many localities do have crisis units that can help intervene if the emergency department, for whatever reason, isn't an option. But usually the emergency department is like the fail-safe. Safety planning. Okay, so if you are not sending a patient directly to a higher level of care, then safety planning has to happen. It's essential anytime you are going to let the person basically leave and go home without, like an immediate next step, right? So they're not going straight to the ER. They're not going to be admitted somewhere. You must safety plan with them. And I would argue that safety planning is important for like literally anybody with suicidal ideations, even if they're going straight to the ER, because eventually they're going to need that safety plan to be able to manage their lives in the outpatient world. First things first, although this is my last bullet point, I do want to just say what not to do. So, no suicide contracts are not effective and they're very outdated, although they do still exist in a lot of settings. They have been shown time and time again not to be effective in preventing suicide. So, although it may be part of your institution's policies or procedures to have a patient sign some kind of statement that they're not going to harm themselves, that alone is not enough. Does not meaningfully mitigate the risk. Safety plans, good safety plans with these criteria that we're going to talk about do mitigate risk. So even if it's part of your institution's procedures to have a patient sign a no suicide contract, you must pair it with something that will actually help them, which is to do safety planning. So the first criteria is that the safety plan has to be patient-centered. So we want to collaborate with the patient. We want to create a personalized plan. We do not want to just hand the patient a pre-written or predetermined template. It's fine to use a template to like help elicit some of this information. You can fill out, some kind of template that is specific to the patient, but we don't want to hand them something that's pre-written that they're just supposed to follow. It should reflect their unique needs and circumstances. We want to help them identify what potential warning signs would be for things getting worse. Like, how would they know that they need to potentially seek help? We want to elicit their own thoughts, feelings, or moods that they think would signal a worsening of their symptoms or signal a need to reach out to support resources. We can provide them examples, but we also really want to get their own input about how they might understand that to occur. we need to include a specific set of coping strategies. So these are practical, personalized coping strategies that the patient ideally is already familiar with, like especially in the settings that you all are working in. You're not having a lot of, you're not going to be sitting there for an hour working on developing some kind of coping skill, right? We're going to rely on what the patient can already do and what they're comfortable using. We definitely, in this case, want to avoid any generic suggestions. I had a patient, one of the examples that always stands out to me, that came to me and said, like, yeah, the ER just told me to go for a walk when I feel this way. And she was like, I live in a neighborhood, like I would literally never feel safe in my life going for a walk in that neighborhood. Okay, great. So going for a walk is not an option, but it was the prescribed coping strategy. Much better would be to get the patient's perspective on what coping strategies are practical for them. Support resources. So this is where we do want to give very specific resources that we provide, right? So things like crisis lines and emergency care, but we also do want to have the patient identify their own support network, right? Who are the people that they can feel connected to right now? Who are the people that they can contact if, it's not necessarily a crisis, they don't need immediate care, but they are having a difficult time. They need to talk through. Remember that just the sense of being connected to others is a really important part of mitigating suicide risk. Um, and means restriction is also a hugely important part of the safety plan. So we want to address any specific means that the patient has mentioned in any plan that they have. And we want to specifically discuss strategies for mitigating access to those means. Um, for the example of firearms, which we want to do regardless, I'll talk about that in a second. But for firearms, like an example would be storing firearms or ammunition with a trusted friend, or a relative or something, or locking them securely and somebody else has the key, code, etc., right? So that the patient cannot access them anymore. Even if a patient does not have a specific plan, they have not identified any specific means relevant to them, we still always want to assess for access to firearms. Just because, again, with suicide being so impulsive and firearms being such a lethal means of completing suicide, if somebody were to make the decision to attempt with those means, then it tends to be very successful. We want to mitigate that risk. And finally, the plan must be mutually agreeable. Okay. So the safety plan has to be something that the patient themselves is willing and able to follow. And also that you, as the clinician, agree is a reasonable plan of action. So sometimes, like a mutually agreeable plan can't be reached. Like the patient might make inappropriate suggestions, like they might not have enough insight to be able to identify some of these things for themselves, or not be agreeable to engage in certain key aspects. Like, hey, if I have these warning signs, I will reach out to, the National Crisis Line, for example. And anytime that's happening, then it is okay to say, like, this is not a mutually agreeable safety plan. We need to think about other options. Perhaps this patient cannot safely return to the outpatient setting, and we need to escalate to a higher level of care. Basically, the takeaway is that safety planning is collaborative. It's a process. It's not going to be done effectively in 3 minutes. It's probably going to take you 15 to 20 minutes. And it needs to be done very, very cognizantly of what the patient is able and willing to do. Okay, so these tools are available to you. This is the safety card. You can access it from SAMHSA. This is the Columbia Suicide Severity Rating Scale. This is awesome. If you are at all feeling unsure or you feel like you need something more formal, most institutions that have protocols and procedures use this. This is a great method or a great screening scale to use because it gives you all the specific questions to ask. It helps you stratify the risk and it gives you some ideas of what triage can look like and what the options are for actual intervention based on the level of risk. The ask tool is pretty straightforward. I like it because if you're in a setting where there's not as much time, this is a pretty quick option. Just please note there's updated versions of these. The National Suicide Prevention Lifeline is now 988. That's not the correct number anymore. Okay. So now let's talk more generally about crisis prevention. So patients who may not have like a current active safety concern, but might be at high risk for experiencing crisis, we should be thinking about like how do we prevent that crisis from occurring in the first place? Um, some things that would put patients into a high risk category would be things like in their history. So typically for the perinatal population, again, any suicidal or homicidal ideation or attempts in their past, especially a history of perinatal psychosis, especially a history of bipolar disorder or other severe psychiatric illnesses, again, all put patients in that higher risk category. And crisis prevention ideally starts very early. If I could, you know, stroke the check, right, to make whatever happen, I would obviously have people start in crisis prevention pre-pregnancy, but obviously in most of the settings that we're interacting with patients, we are typically starting to see and interact with these patients when they're already pregnant or already postpartum. So that's fine. You just start as early as you possibly can, and know that starting now is always better than not starting at all. Okay. When we're thinking about the early steps of crisis prevention, we want to do that comprehensive risk assessment. So we're going to assess the full spectrum of risk factors, not just the psychiatric diagnosis, like those risk factors that we talked about, for example, with suicidal behavior. Understand the patient's history, ideally, and their current circumstances to figure out what their risks might be. We want to optimize treatment. So in patients that have these high risk factors, especially those patients that have existing psychiatric illness, we want to ideally get those illnesses well managed. Optimization of care can significantly reduce the likelihood of crisis occurring. And ideally, we're going to establish support resources early on for pregnancy and postpartum, um, helping the patient basically to develop their social network or network of support resources in general. So that can include, again, family or social support, specialized mental health providers, community resources like support groups or maternal mental health programs, anything that can kind of buffer this patient for potential crisis that could occur. Um, One of the things to note is that, I think supporting high risk patients ideally involves like an ongoing relationship and an ongoing effort, but not all of you work in settings where you're going to be doing that. So any of these things that we're talking about with crisis intervention, wherever you interact with the patient, anything that you can inject into that meeting, that like interaction that aims that fits these aims of crisis prevention will be positive. Ideally, if you are in a scenario where you're working, more longer term with the patient, like I heard a few therapists, for example, providers who would have ongoing relationships, I would recommend holding one or two postpartum planning sessions. If you can, aim for at least an hour devoted to this planning. And the sessions should include both the patient and a trusted partner, like a spouse, a partner like the other parent of the baby, another family member like the patient's mother or father. And family members really are like often the first line of defense in recognizing concerns. They can sometimes be the ones that recognize things before they get to crisis level, but when they're needing intervention and support. It's not their job to diagnose or assess safety risks specifically. We just want to give them the information that they can use to be able to identify like when to reach out to the professionals for help. Um, so some key areas that you could include in any education that you give to the patients or family would be, of course, signs and symptoms of any safety concerns, things like recurrent thoughts of death or thoughts that the world or others would be better off without them. We do want to include education on perinatal psychosis if we can, teaching patients how to recognize like early warning signs like mood episodes, things like that. Again, please go back to review the prior lecture for more information on that. Any odd or unusual behavior, things like the patient just doesn't seem like themselves, right? The patient doesn't seem like the person that I know. The patient themselves may be able to identify, I just don't feel like me. And also we want to educate about the potential for waxing and waning of symptoms. This is especially important in something like perinatal psychosis, but we see this in general that, it's not that the person always feels suicidal, for example, every moment of every day. And sometimes there are periods that the person feels better and feels worse, but those periods of feeling better, or the periods where the person seems more like their normal self, do not necessarily mean that the crisis has resolved and should not stop the family or the patient from seeking care. Sleep is a hugely critical component of crisis prevention for perinatal patients, and it should be included in any crisis prevention education that you provide. We did, excuse me, a whole topic on creating a protected sleep plan, so you can go back and watch that webinar if you can, to look at all the details of what that plan should involve. Just a couple of points. If patients are deciding to breastfeed or lactate, it's important in that plan to include some kind of plan for like how they're going to remove milk overnight so that they can optimize sleep, like minimize the sleep disruptions from that. Sleep deprivation is also a known trigger for postpartum psychosis, so that's especially important in patients with bipolar illness or at a heightened risk of psychosis. We also ideally, especially for very high risk patients, patients for whom, they may have had other psychiatric crises, like we know that they're in that really high risk category, would probably want to help prepare them for, and the family for like what they might experience if they actually do try to seek help in a crisis. So what happens, for example, if the patient refuses help? What does the family do? Talk about potential risks and how the family can support their loved one and how they can respond, like what interventions they can take on. What happens if the patient seeks help but is turned away? Unfortunately, this can happen. This has happened. This has happened for me sending patients to like the ER, for example, and emphasize that the response should typically be to try again. So that might mean calling you, returning to the emergency room, contacting another resource, whatever it is, but basically don't give up. Unfortunately, with sometimes the way that our mental health care system is, people doing assessments in the settings where we send folks for higher levels of care might miss the symptoms being as severe as they are, especially if they're waxing and waning or things like that. And then what happens if the patient is admitted? I think it can be really helpful, or in general, maybe what happens in the process of potentially becoming admitted to a higher level of care. I think that can be very helpful for patients to just have an idea or an understanding of like, is this going to look like? Even just a patient recognizing that they may be in the ER for a few hours, or longer, can be super helpful so that like after, 2 hours, the patient and family aren't just like ready to give up, for example. Like what happens then after that? Like who might see the patient and talk to them, and what might the process look like if they do end up going to the hospital? Ultimately, all this education basically just empowers the patient and their family to be their own best advocates so that, if they're not connected to any firm resources, they still have the tools they need to prevent crisis. Okay. Once we get to the point of crisis, then we need to intervene. So we're going to talk a little bit now about crisis intervention. So the first step is recognition. We've talked a lot about this already in talking about suicide risk assessment. But there are some other things that generally we can look out for, especially in the perinatal period, that might be a warning sign that either crisis is occurring or crisis is imminent. Expressions of hopelessness or worthlessness, like, for example, statements like, there's no point anymore, I'm a burden to everyone. You could think of those as like covert sort of suicidal statements, but they may just be expressions of hopelessness. Sudden or extreme increases in anxiety or agitation, patients who experience like unusually restless behavior or feel very, very overwhelmed. Other sudden behavioral changes like withdrawing from loved ones, neglecting self-care, appearing unusually calm after a period of distress. Again, those overt or covert suicidal statements or plans. Expressions of feeling overwhelmed or unable to cope, like I can't handle this anymore, I just want it all to stop. Again, those accessing means or making preparations of any kind. And anytime a patient identifies their own concern or a family member identifies their own concern, we listen. It doesn't have to be anything specific on this list. If the patient is worried or the family is worried, we're worried. Psychotic symptoms also are an important thing to be able to recognize. Remember, psychosis is an immediate like crisis. It's a psychiatric emergency in the perinatal population. and requires an emergent intervention. Delusions are false fixed beliefs that are not grounded in reality. Hallucinations are hearing or feeling things or seeing things that aren't present. Command hallucinations also occur. Those would be hearing voices telling the patient to act in a certain way, and disorganized behavior. So actions that seem erratic, incoherent, or inappropriate. And then finally, impaired insight or judgment. So that's another really critical sign that there's crisis is imminent or that the person might not be able to manage their own safety is if they have poor insight or judgment. They could maybe be lacking the ability to recognize the severity of their condition, or they're making poor decisions. They might downplay their symptoms, refuse help, or just generally act in ways that demonstrate to you that there's a lack of awareness about the risk to their safety. Um, when we do actually intervene and move towards sending somebody to a higher level of care, this would be when a patient is identified as a high safety risk. So that means they're either experiencing perinatal psychosis or they have like an imminent high risk suicidal ideation, for example. The goal is to transfer the patient to a higher level of care, and ideally we do this voluntarily. Whenever possible, we want to work with the patient and their family and gain their support to transfer to the higher level of care. In some cases, direct admissions can be possible in that scenario. So you may have access to a medical provider or like a perinatal specialty unit that can arrange a direct admission, but most often patients are going to have to go through an indirect admission in the emergency department. That's in most outpatient settings, OB offices, community health clinics, even in outpatient psychiatry, very often, because of the nature of the fact that patients in our population are pregnant or acutely postpartum, they have to get medical clearance in the ER. So they'll have to go through there anyways, and the ER will do their own evaluation and admission. Involuntary admissions occur if the patient refuses voluntary care. So an involuntary admission can be necessary sometimes. Most often, this process involves police. There are some places that have specific behavioral health crisis intervention teams that will do some of this work, but most often police are involved at least to some degree. So when you're requesting police assistance, it ideally you would ask for crisis intervention trained officers. Those are CIT officers, and they have specialized mental health crisis training that ideally trains them to de-escalate situations and minimize any trauma during a mental health crisis. And finally, we're going to ensure the patient is safe during the transfer. Okay, so we want somebody responsible to remain with the patient for the entirety of the transfer process. So, for example, if they're leaving your outpatient clinic and they're going to an emergency department, somebody has to be with them that whole time. They're not going to be alone at any point until they are in the hands of another healthcare facility or provider. Okay. It's sometimes, relying on family members or trusted others that the patient, is related to, that can get the person there. And you can basically just do your best to assess if the person seems reliable and if you feel like you can trust the person to help them get the patient to the next place, that's reasonable. Otherwise, sometimes that will mean a staff member going with the patient. And then finally, you want to document. You follow up and document the outcome of the transfer. You want to verify that the person has actually, arrived at the ER or inpatient facility. What was the outcome of that? Were they admitted? Were they discharged with resources? If the outcome wasn't expected, like you were thinking they were going to get admitted, but they didn't, follow up with the patient, reassess, determine the next steps. Don't just kind of leave it, ideally. The key thing I think here too is just remembering that at any time there's a crisis situation, like we act now. We don't delay action. The patient doesn't leave the office and then come back the next day and we do this tomorrow. Like this can be very intense for patients, but we want to spend as much time as we can to reassure them, but move them directly to the higher level of care. Okay, last thing. I want you all to be able to differentiate intrusive thoughts from true safety concerns. So this distinction matters because intrusive thoughts are incredibly common in the perinatal period, particularly postpartum. Most of the research suggests that probably 80 to 90%, there's actually some research that says 100%. I have trouble believing that's actually 100%, but 80 to 90% of new mothers experience intrusive thoughts, and probably half of those have thoughts about harm coming to the baby. Sometimes that's accidental injury and sometimes it's intentional harm. Um, Even though they're extremely common, intrusive thoughts are often misrepresented as safety concerns, and they lead, in some cases, to unnecessary escalations to higher levels of care. Um, the characteristics of intrusive thoughts are that they are unwanted and distressing. They tend to be repetitive and persistent. So the thoughts recur pretty frequently, often in a way that feels pretty difficult for the patient to control. They tend to be related to anxiety. So the individual might feel really anxious about the thoughts or surrounding the thoughts, or anxiety might drive avoidance behaviors. So these are behaviors that help the patient basically prevent the thought from coming true, prevent the thought from happening. And the key distinction is that these thoughts are ego dystonic, okay? So they are unwanted, irrational, and inconsistent with the person's values or desires, and the patient recognizes those thoughts as irrational and unwelcome. In contrast, usually delusional or psychotic thoughts are ego syntonic because remember, they are part of a fixed false belief. So the patient does believe them, they align with that patient's worldview in the moment, and the person accepts them as true. Patients with intrusive thoughts will maintain good insight and judgment, and they will not have a plan or intent to act on those thoughts. Okay. So you can use some of the same risk assessment strategies and risk stratification from plan, intent, and means to assess whether there's any imminent risk of harm. Um, Again, anytime you can do a thorough risk assessment, you're going to be able to identify really what the level of risk is much better and be able to intervene appropriately, whatever type of thought you're dealing with, whether it's a true suicidal thought, an intrusive thought, etc. And we use all the same skills. All right, we're at 1 minute past, and I did finish. It was a big lecture. It was a lot of material. I can stick around for probably 5 minutes if anybody has any questions, but thank you all for joining.
Thank you, Dr. Reichenbacker. I was kind of letting you go because I knew you usually have a meaty presentation and we often don't have very many questions. So I was like, I might as well let her continue. I do see one question in the chat that said, "Oh, and that's a person that had to leave. So sorry."
Okay, no
I
problem.
will I will ask the question though. That way it'll be on the recording if they want to try to go back.
Okay.
It's how do we conduct these screens and assessments and do our best to be sensitive and not re-traumatize the patient or client? In your experience, does asking these questions trigger clients or patients?
In my experience, no. One thing to think about too is if we are dealing with an potentially imminent safety risk, right? If somebody is experiencing suicidal ideations, especially if they are somebody who may be at high risk of suicidal action, um, even if there's a risk of potentially some level of traumatization, that would be outweighed by the benefit that we could do by actually asking those questions directly and making sure we get as much information as we need in order to make a good decision or help the patient make a good decision about the next steps and keep them safe. So safety will always trump that, even though obviously we want to be as sensitive as possible. I truly have never had an experience where it seems to me that the act of somebody asking about suicidal thoughts in a sensitive way, right, would lead to any traumatization. If you're doing this from an empathetic perspective, like you want to help and you're asking because that's what you want to do, you're not asking just because it's a box to check, then I think that you're at very low risk of traumatizing somebody.
Okay. I don't see any other questions. Some folks saying thank you. And one person said, "This was so helpful. You made a difficult topic accessible. Thank you for your work and advocacy." And I like to echo that. Very, very dense content that you made very approachable. So we appreciate you and we appreciate you and the rest of your teammates participating in this series. This does wrap up the perinatal mental health safety series. If you would like to view this or share it or any of the previous episodes in the series, please check it out on our YouTube channel. Thank you, everyone, for joining us today. Hang
Guys,
back just quick, real quick, Olivia, and
yeah,
we'll
sure.
see all of the rest of you next time. Thanks.